there's a one particular sentence which kind of is very overwhelming. So it basically says a blind man is a mouth without hands. Basically means that you are a liability to your family. You don't contribute, but you are a mouth to be fed.
Okay.
So we basically have been around for about 14 plus years.
Yeah.
We have 8 products in the market, touched about 16 million lives.
Wow.
We have crossed about 3,800 odd installations cumulatively, close to 4.5 to 5 million transactions over the cloud. We have done about 800,000 to 1 million corporate screenings.
Hi, welcome to the episode of Forus Health on Tap. Today we are sitting down with Mr. Chandrasekhar to understand his journey building Forus Health over the last 14 years. He also comes from an interesting semiconductor background before starting up. Let's deep dive into his journey and understand more about the eye care industry. Hi Chandrasekhar, thank you so much for coming on Tap today.
Thank you very much for the opportunity.
Yes, looking forward to the discussion today. To start with, why don't you maybe help us understand a little bit about your journey and your background and what led to this current position that you have at Forus Health?
Yeah, so I graduated from Bitch Pilani and spent, I think, the first 20 years, close to 20 years, predominantly in the electronics and semiconductor industry. And my last job was director of strategy for NXP Semiconductors, which was Philips Semiconductors.
Okay.
Basically, this was in 2005. We were part of Philips Electronics, which is the innovation center here in Bangalore. And we were at that time in Philips. Philips was looking like losing a little bit of market share in this part of the world.
Okay.
So the Philips management in India were very keen to look at what are the new things we should do or innovate for India-like countries.
Okay.
So I was fortunate to be part of the team. And so we basically were looking at what could be the new innovations we should do. And this was like very broad-based. It was nothing connected with semiconductors or appliances or medical, which is connected to Philips. It was general, very general, right? And in order to facilitate that, there was a consulting firm which came and kind of facilitated this innovation.
Right.
And part of the facilitation, they basically brought in case studies of a few companies in India or institutions in India which did innovation, completely different from where Philips was. So there was Dainik Bhaskar, which is a newspaper, nothing connected to Philips. There was Shanta Biotech, the drug for cancer. Then there was Pratham, which was in the education of slum children in Mumbai. And then there was Dr. Arvind from Arvind Eye Care, Madurai.
Okay.
So basically we had the opportunity to listen. It was a shame that I actually didn't know that an organization like Arvind existed. And it was from Madurai. My mother was actually, she was not from Madurai, but she was brought up and she educated and all that. So there was always a little bit of sentimental connection there. And so when he came and spoke about us, it was very inspiring, obviously, like anybody else. And so then it took, we had the opportunity of going and visiting them and, kind of learning what was going on. And at that point of time, I was obviously not mentally ready, or in fact, I was more clear, like I wanted to have a corporate career, kind of retire in Philips kind of thing.
Okay.
Never thought I will become an entrepreneur. But I think the more I got connected with Arvind and started spending a lot of weekends going to Arvind, kind of made me to look at, if we believe that this is a very important cause, why should we not look at it? So that was how it started.
Oh, interesting. So, so after that session happened, you were in touch with Mr. Arvind?
Dr. Arvind and the entire team. So we were fortunate to actually meet Dr. Venkataswamy, who's the founder of Arvind, before he passed away. He's called Dr. V. So there is this amazing video called Infinite Vision, which is there. You can watch on YouTube. There's also a book. So there it basically there's a one particular sentence which kind of kind of was very overwhelming. So it basically says a blind man is a mouth without hands, which basically means that you are a liability to your family. You don't contribute, but you are a mouth to be fed.
Yeah.
So, and when we started listening to those stories, and especially a lot of people who became blind, so Arvind's mission was eradicating avoidable blindness.
Okay.
India was or is still the largest blind population in the world, and the most ironic thing was that 80% of this could have been prevented if they were screened and treated on time. And a lot of people will not know India has only 20 to 22,000 eye doctors, ophthalmologists. So we're talking about one doctor for 70,000 population.
Insane.
So these are things which I came to know once we started going there. And original idea was to see what tech we can do to kind of, even from Philips initially, right? But then Philips was not in ophthalmology. So because we got emotionally connected with the problem, started going at a personal capacity weekends and kind of understanding why is this problem existing, right? And can we really do something? So understanding from, let's say, a patient perspective, the person who's accompanying him perspective, the doctor's perspective, the nurse perspective, just trying to understand why they came now, why did they not come before, what is their problem, what is that we can try and do better. So I think those are the things kind of evolved. So it took us like 3-4 years to kind of even understand what is that we need to do.
Okay.
It was not like I really said, oh, from tomorrow I'm going to jump into that.
Yeah.
And also didn't have any prior experience in making medical devices, or I never even thought of becoming an entrepreneur, right? So it was not. So the continuous involvement and kind of repetitive meeting kind of mentally prepared us that we should do something. If we feel that it's an important cause,
right,
we should do something. And that's how it kind of evolved.
Interesting. So the cause is definitely something which probably a lot of people don't associate with. Somebody who's seen this happen very closely to them, they are more empathetic towards this problem. In fact, when I was studying doing my MBA, there was a blind school close to our campus, and we visited there once, and they had this one experience where they built this one blind room of sorts.
You will go dark and you're trying to kind of figure out.
Yeah, and you can't see anything, and that's when you really realize what it's like to be suffering through that problem all your life. And for somebody who's never seen the world, right, it's such a grave problem, and most of us just can't associate with it. So it's definitely a very noble cause that you all are working on.
Actually, it's still worse, right? Like, for example, a blind person, probably if he's blind from birth, he actually doesn't know what is light.
Yeah.
But these people are people who have actually lived for 30, 40, 50, 70 years with vision. They have seen everything. And losing that is actually much more traumatic, right?
Correct.
And there's a lot of study which says, especially people in the lower economic strata, the moment they turn blind, if they would have lived for 10 years, they probably pass away in 3-4 years because they feel a little neglected, not wanted,
right.
And the worst part is most of these people are people who have started working from their 8th or 9th age, probably worked till 70.
Yeah.
The time where they should have a very dignified death.
Correct.
They actually die feeling that they are not relevant to their own kith and kin. And you actually can't blame the kith and kin primarily because they are actually into daily wages.
Correct.
They can't sit and babysit their parents or grandparents. So it's like it's a very economic as well as a very emotional problem.
Right.
And given that we have less number of doctors, ultimately, we felt that maybe we should think of what we can do from technology to kind of solve the problem.
Correct. So now that we understand this problem, can you also help us understand how Forus Health is solving it, especially with different types of products that you've launched, keeping technology at the core?
Yeah. So, during our visits to Arvind and also kind of looking at it from, let's say, at a backseat and seeing, okay, ultimately we'll have to build a commercial organization if we have to do this.
Yeah.
So we have to build a very sustainable and scalable business. And we want to fundamentally work on the vision of Arvind or mission of Arvind, same as that, eradicate avoidable blindness, but the only thing was using technology. So that was the. So we kind of started looking at what is actually the first big bottleneck.
Okay.
So, so the problem statement was very clear. Like, okay, there are a lot of people going blind, less number of doctors, less awareness about eye problems. So this is a large statement. Now, if we have to solve this problem, one of the basic understanding we got was that people go to an eye hospital very late.
Okay.
In the overall journey of the disease.
Okay.
So the awareness is a problem. Obviously, in a lot of places, access and affordability could also be a problem. So there is probably only 15% of the population having access, affordability, and awareness and reaching an eye doctor.
Okay.
So if you have to eradicate avoidable blindness or stop preventable blindness, then you need to be closer to the end consumer and start doing preventive care rather than a time where, he comes, it's a little advanced stage of a disease.
Yeah.
So if we have to do that, the first, at least the bottleneck what we saw at that time, primarily was the devices, which was the devices which were required at the point of care.
Okay.
So we said, okay, let's start looking at, can we make a device as a starting point? And then, again, we didn't want to look at what was existing. This is a very typical thing, like look at it, strip it, make it low cost, nothing like that. So we said, okay, now this is the problem. We're going to look at this problem very differently. So if I have to have a black box, which can actually be put in many locations, like not just an eye hospital, but let's say a railway station or a mall where anybody will go.
At common public places.
At a common public, where we can screen a person for a common eye problem.
Okay.
And tell him he or she has got an issue. Then he can go to an eye doctor for treatment. So this is the very top level thought process.
Right.
So if you have to do that, what should that device be? So we said, okay, one, it should do imaging of the eye without dilation. So dilation is a process where they put the drops in the eye hospital. Why? Because when you're doing preventive care, nobody is going to give you 2-3 hours of dilation and wait, right? So you're saying, okay, you come to the mall, I'll take a picture of your eye, give you a report within 1 day or a few hours.
Yeah.
Okay. So if that is the case, this device has to take an image without dilation, one. Second, it should be used by a technician or somebody who's very minimally trained. Right. Because if it requires a sophisticated operator, again, you're putting a bottleneck.
Correct.
Right? So it has to be very minimally trained. And obviously, it has to be portable and rugged and cost effective and all that.
Absolutely.
So that was the starting point. So we started looking at what is the first thing. We said, okay, we'll do adult retinal imaging.
Okay.
So that was the starting point for us. And then we also felt that refractive error was a bigger problem. So we'll initially combine refractive error, front of the eye imaging, back of the eye imaging. 3 devices into one. And that's why it was called Trinetra.
Oh, okay.
So Trinetra was actually the first product idea. But ultimately it became our brand. Okay, right. Forus Health is a company name, but Trinetra became a brand. There's also a slightly philosophical story behind it. As per our Hindu mythology, Lord Shiva has got the third eye. So the third eye is supposed to look at things what the normal eye cannot do.
Correct.
And also in our stories, it is there that supposed to be that Lord Shiva opened his third eye in Madurai. So our third eye got opened in Madurai, right? So Trinetra looked a very apt name and it was doing 3 different functionalities, original idea.
Okay.
So in the process of building this, the most difficult part was building a device for taking the back of the eye image, which was the retinal camera, what we call.
Correct.
And once we made that first, we felt that product as a standalone has a market, right? And of course, after another year, we built with the refraction and made it the real Trinetra as we saw. But of course, we started naming it in different nomenclatures. So we started looking at product as the starting point, which is medical devices, which was with these basic specifications. Now, jumping back to the overall philosophy, right?
Yeah.
Even though I said like preventive care means we are going to screen people anywhere and everywhere, right?
Right.
But in a deployment strategy, it doesn't work that way, primarily because your product must get credibility.
Okay.
Right? Ultimately, because a common man, you just say that, okay, I made something, I'll screen your eyes. Who are you? Right?
Yeah.
Rather than that, if I say, okay, I am supplying to the big names, Arvind or Shankar Netralia
Yeah.
or LV Prasad, then you have credibility.
Absolutely.
So our deployment strategy started from that, okay, even though I'll make this, I'll start to build credibility by selling it to ophthalmologists. That was also a sustainability and scalability model. So we
Yeah.
started with that. Once we made that, then we asked the basic question like, okay, now I want every ophthalmologist to start using it, because we had, so the retinal camera, like in eye, there are subspecialties. There is anterior segment, which is the front eye, so front part of the eye, where the number of doctors are very large in that. Out of the 22,000, almost 12,000 or 13,000 doctors on the anterior segment. They are the ones who do the cataract surgeries and all that.
Okay.
Retina doctors are very less. They are like 2,000-3,000.
And what is the reason for that?
Yeah, so cataract, again, the reason for that, I don't know. This is my guess is, cataract is a more prevalent problem. So the number of surgeries required was high. So I think more and more doctors adopted for anterior segment specialty. I think as diseases start to increase, all the subspecialties will also start to increase, the number of doctors coming there. So when we started selling to retina doctors because they were the ones who needed. But some retina doctors already had cameras because they are not waiting for us to come, right?
Absolutely.
So we created a model for them where, okay, they can open a hub and spoke model where they can have a high value camera, which they already had in their main center. And they can use these satellite centers with our cameras where it can act as a feeder. So that was the starting point. Then we actually went into the anterior segment doctor. So from 2000, the number of doctors we could serve was 12,000.
Yeah.
Okay. So there, the anterior segment doctors earlier never looked at retina because they were not able to they were not treating them.
Right.
And also they were not screening them because the cost of the cameras was so high. It was not, and since I'm not solving the problem, there's no point in me doing the screening.
Yeah.
But because we started making the cameras at affordable prices, the anterior segment doctors started to also screen for retina.
Oh, wow.
So we built that. So then we asked the basic question that we went from specialty to generalist, which is in ophthalmology. From there, can we go to the generalist, which is the GPs, which is primary care.
Yeah.
So 2,000-3,000, 12,000, then 500,000.
Yeah.
So then when you go to 500,000, so the 2,000 and 12,000 are ophthalmologists. They can buy a camera by practice. So capital equipment buying was a given. But when you go to primary care, obviously that's not their specialty, right? So the idea was that if we put it in a place where people are coming with a health-seeking behavior, so they're coming to a GP with a health-seeking behavior, they're also coming with an intent to pay, because fundamentally it's not a insurance-based market in India, right? Everything is out of pocket. So we can introduce a simple eye screening at a low cost at that location. Okay, but then in a GP, obviously he is not going to spend. This devices were in the 4 lakh, 5 lakh range. So a GP is not going to spend a 5 lakh on a camera which is not connected to his core business.
Correct.
So if you have to go there, then we felt that we need to build a platform, right? So and change the business model to subscription model, not just selling devices. The same thing was applicable to public health, because when we were making devices and making an impact, we felt the impact was good.
Yeah.
But the impact was still within the ophthalmology circle.
Correct.
Right. So if you have to expand the pyramid, we have to go to public health, government and all that. But when you go to government, and let's say that I go to, let's say, a health minister of any state, tell him, look, diabetes is a big problem. 1 crore people are affected by diabetes. And of that, about 30% will lose vision.
Yeah.
And by the way, you'll have to buy my camera to do that. And this is the field of view, blah, blah, blah. So it becomes a very technical discussion, right? There is a disconnect. You started off with diabetes. You said, okay, you have to screen. And then you went into product specification. Doesn't go very well with anybody who's actually looking at it at a macro level.
Yeah.
Instead of that, if you tell him, so you have 1 crore population, and in order to screen them, you probably have to spend, let's say, some number, 20 crore. And I'll give you everything. I'll give you the hardware. I'll give you software solution, and it'll ensure that, people can be screened in PHCs and CHCs, and your doctors can grade it. In order to make that statement, which is directly communicating to them, look, for screening 1 crore people, you require 20 crores.
Yeah.
And with 20 crores, I can probably solve, or 200 crores, I can solve this problem. So that is something which they can understand.
Correct.
But in order to make that statement, you have to be prepared in the back end, which
Yeah.
is building the platform. So we started building that platform. We're very fortunate that the Andhra government initially started adopting it. It was called the Mukhyamantri Eye Kendram. Apollo
Okay.
became the implementer. We supplied the hardware and software.
Yeah.
And then we again came back to this. So okay, now you are expanding, you're going. You still again come back to this bottleneck that, okay, the doctors who are grading
Yeah.
are comparatively again less. So that is when artificial intelligence became an important component. So can you kind of use AI to identify a disease from an eye? So that was the first point. Then going one step ahead, because you're deploying it in primary care, can I use this opportunity, because retina is considered as a biomarker, or it is eyes window to your human body.
Correct.
So retina, there have been studies for the last 30, 40, 50 years, not that we have invented that you can use your eye image to identify some of your systemic diseases.
Okay.
A cardiovascular risk, or a neurological issue, or a nephrological problem, some of the autoimmune disease.
So it reflects in the eye.
Yeah, from the same retina image, can
Okay.
we kind of figure it out? So
Okay.
because we are slowly deploying this in primary care,
Yeah.
can I not identify, apart from your eye problems, can I not tell you that you seem to be a high risk case for a cardiovascular issue or
That
a
is
neurological
really
issue?
fantastic.
So started building around that. And then of course the last piece was that we were also feeling that while the hospital, clinic, ophthalmology based network was improving, there was also a lot of need and awareness building which was required at the last mile itself.
Okay.
So we started to look at, can we do the last mile services? We also initially thought that because we made product and platform and all that available, a lot of service providers will start to offer the last mile eye care.
Right.
But I think in the healthcare, unlike other e-commerce or scalable businesses, eye care is very, very domain specific, right?
Yeah.
Like you can't have a very generic platform for all diseases in one.
Right.
Maybe, a hospital doctor connection platform is okay. But when you get into the diseases,
Yeah.
it has to be very domain specific.
Yeah.
So we felt that maybe we may have to build that and show to people so that some of the large service provider can actually adopt that going forward. But in order to prove that, it may be very important for us to kind of also establish the unit economics, the scalability, the impact it creates.
Correct.
So we started doing a last mile screening ourselves, and then identifying people with problem and connecting them to hospitals. So today, if you really look at what Forus does,
Yeah.
so we still make medical devices, and in the medical devices we have three major areas. One is in the adult space. The second one is in the neonatal space. It's a very interesting thing. I can talk about it later. And then the third one was refraction space.
Okay.
These three is what we do. Then we started building the platform. So the platform today has done close to about 5 million transactions.
Oh, wow.
And then started building the AI part, and then started doing the last mile screening part. So that's broadly what we do.
Very, very interesting spectrum of solutions that you've built. And I love how all of this was coming from what you were observing on ground and purely.
And again, if you see, it's not deviating from the mission of avoidable blindness. So even though it is, it's helping us to increase our revenue, increase our reach, increase our impact, but it's still very, very much connected to our mission. So we're not doing it like we're not doing AI because it's
Cool.
the buzzword or cool, right?
Yeah.
It's very relevant.
Absolutely. So there are a couple of things which are very interesting in how you explain the whole journey. One is you definitely want to understand how. So you said that there are about 5 million transactions that have happened. How many lives have you impacted? Is there any metric?
Yeah. So far, if I have to say all the metrics, one shot. Okay. So we basically have been around for about 14 plus years.
Yeah.
We have 8 products in the market,
Yeah.
different products. We have touched about 16 million lives.
Wow.
We have crossed about 3,800 odd installations cumulatively.
Okay.
These have gone to about 70 plus countries.
Okay. Interesting.
And all our ground up innovation. So we have like 7 patents awarded and about 12 patents in the process.
Fantastic.
We have AI for about 5 ocular diseases and 8 systemic diseases.
Okay.
And then we have done about close to 4.5 to 5 million transactions over the cloud.
Very interesting.
And we have done about 800,000 to 1 million corporate screenings. So
okay.
This is the
a very interesting report card, if I were to call it. Can you talk a little more about your innovation with AI and how that is really impacting this particular field? And recently, I'm sure you would be keeping a tab on how Elon Musk has come up with Neuralink, and that is actually showing potential to solving a lot of problems that currently are unsolvable in terms of diseases. How do you think is the future of AI, especially for eye care?
Yeah, I think it's unlike a very market-related, people-related, which has got direct impact. Healthcare, there is technology. First, there is a potential patient. There is technology. There is a doctor, and then there is the final. So it's an ecosystem, right?
Yeah.
So the ecosystem also consistently have to mature. There is actually no point. Actually, it's counterproductive. Like, let's say I screen 1 billion people in India and identify 200 million people with problem, and there are no enough doctors to solve the problem. Actually, you're doing more bad than good.
Yeah.
So we need to kind of ensure the ecosystem consistently is growing, and we'll have to kind of slowly ensure the ecosystem is also ready. So I think that's actually the most critical thing what I see.
Okay.
Now, if you really look at it, the way we have evolved, products made doctors try new business models. I think retinopathy of prematurity is a problem that not many people will really know. So this happens with premature babies. So babies who are born less than 1750 grams or born before 28 weeks are termed as premature babies. Now, earlier these babies used to anyway die because lack of development of organs and lack of facilities. Tremendous effort by the government. Government NICUs have come up and private NICUs are there. So lots and lots of babies are getting saved.
Okay.
Now, which is very good.
Yeah.
Now, the problem is when these babies are put in incubators, they kind of get oxygen, and which is very good. But sometimes it acts counterproductive, especially for the growth of the retina.
Oh.
And the retina can grow irregularly, and it can lead to detachment within 60 days, 40 to 60 days.
Okay.
Now, if you don't screen and identify that problem and treat them, the babies will go permanently and irreversibly blind.
Oh.
India has 3.5 million premature newborns every year, which is huge.
Yeah.
So the technology, so there are 2 technologies. One is obviously the doctor, the ophthalmologist uses an indirect ophthalmoscope where he looks at the baby. The advantage of that or disadvantage of that is it only offers a 45-degree field of view, whereas the disease happens in the periphery of the eye. Okay. So the ophthalmologist should navigate and see to the edge of the eye, and he should be physically present where the baby is, which is not possible in all cases.
Correct.
also, medico-legally, it is important. You can only see, you can't document it.
Okay.
Right? So medico-legally, it is very important that they have to document it. So a neonatal retinal camera actually takes a wide angle imaging and it helps the doctor to take a call whether the baby is having ROP. And the most important thing is the prevalence of ROP could be like 35 to 50% on every premature.
Okay.
Right? But not everyone will require an intervention. About 7 to 10% requires intervention. But you'll have to monitor them.
Correct.
Whether they fall in the normal category or they fall in the 7 to 10% category.
Right.
So it becomes very important to have this wide angle retinal camera. And prior to us, there was one camera which was available, made by a company in the US, and it was costing like $150,000, $130,000, completely not affordable.
Yeah.
So we made, and it was also like a 25, 26 kilogram weight product.
Okay.
So we came up with this product in 2017, where we were able to make a product which was 8 kilograms total, which goes in a cabin bag, and the probe was just 340 grams.
Okay.
The 340 grams which touches the eye is only 340 grams. And then it was completely portable, and it was in India. The price point was roughly in the order of magnitude of about $25,000. So it's
Wow.
yeah. And then the next generation version is today the most advanced product in the world, right? So
Interesting.
that product is, I would say, from an innovation perspective, it's not a poor man's product. It was a product which actually is selling at the top of the line hospitals in the US or Europe.
I'm sure.
Right? And it is also a product which is made affordable. So prior to this product being available, there were probably like 10, 20 installations in India.
Wow.
We have, in the last 5-6 years, 300 plus, 400 plus installations. So we have been able to make a difference to almost 800,000 babies globally.
Amazing.
Right? I'm assuming that about 100,000 of them, if I take that 10% rule, about 80 to 100,000 of them, we would have helped ensuring that they didn't become blind at birth. So that is, from an innovation perspective, gives us phenomenal satisfaction. Also from an impact perspective, but from the innovation perspective, because this product was completely designed by us, manufactured by us, and it is going global. And in fact, it is even going to a place in Japan. So normally we take stuff from Japan, right? So sending a device, exporting to Japan is a real feel good. It's a feel good factor as an Indian as well as Forus Health employee. So it gives us a lot of satisfaction. So I think that was the starting point.
Okay.
Then obviously we had access to a lot of ethically stored images, which we were consistently. So even before AI became a buzzword, in 2010-11, when we even started, we were calling it. Our idea was that we will make a device and we'll also make what we call a CDSS, computer decision support system, which was algorithm based, not deep learning based, but fundamentally the same methodology, right? Where we take an image and say, okay, this person has got a problem or doesn't have a problem. That was the original idea. And if he has a problem, connect them with a doctor over telemedicine. This was our original thought process.
Okay.
But then as we started building the products, we had to focus more on that. And then we were doing all this in the back burner.
Yeah.
But I think AI acceptance is also just starting. It's not like there's a lot of noise, but on the ground acceptance is not very great.
Right.
So our idea was that we have to ensure that we build this for a real life using, because a lot of times you find in AI, people have tested it in test conditions or ideal conditions where everything is good, right? Like good hospital, good camera, very high-end camera, dilated patients, no issues, good operator.
Which is very rare.
Which is very less.
Yeah.
Now, if you want to deploy it in a village where the lighting conditions may be bad, non-cooperating patients, in the sense people who are old and all that. So you will have very limited opportunity, and your AI shouldn't say it's an ungradable image. So we need to kind of build that intelligence to ensure that it is actually usable in the real world, which is in the real use case. So
Yeah.
who the operator is, who the doctor is, irrespective of that, it should actually work at a decent level. So that was the challenge which we started to work. And
Okay.
the opportunity was that in all our corporate screenings, we ensured that the image passes through our AI and then goes to a doctor. So the final report was always from the doctor, but it gave us a huge opportunity of almost screening about 600,000 people in different light conditions, different operators, different settings, graded by different ophthalmologists, which is actually what the reality will be.
Yeah.
And then start to see at what level of sensitivity and specificity our products are.
Correct.
So we started building that slowly, and we were not giving too much of noise, primarily because we also wanted to have the acceptance. And the other important thing is, um, when a doctor looks at the eye, he looks at all the problems,
Right.
right? But when you're doing with AI, you're looking at 2 or 3 diseases, which is predominantly the bigger problems.
Right.
So it's very important that we have to at least build those AI for all those, like glaucoma, diabetic retinopathy, macular degeneration, which constitute almost 80-90% of the retinal diseases,
Correct.
right? Only then it makes sense, because then you are helping the doctor far more better. So
Exactly.
that was probably the way we saw. I think you asked a question on how do you see AI playing a role. I think the acceptance has already begun, but I think large scale implementations will still take time. I think it will take like 2-3 years,
Okay.
depending on how proactive the provider. It's not about how good the AI is, it's more about how proactive whoever the user is.
Yeah. The
And then it'll
adoption.
gain more and more popularity, and then it'll also improve, like the sensitivity. It'll all improve as we keep going. And I think at that some point of time, it will be used as a clear triaging agent. So it will definitely 200% never replace a doctor. That's
Yeah.
very clear.
Yeah.
It will be a huge assistance to the doctor.
Absolutely.
And then, like somebody said, right, it's not like there'll be, AI will replace a doctor. Actually, doctors who use AI effectively will replace doctors who don't use
Yeah.
AI effectively. So I think that is where the difference is going to be. It'll be a very, very assistive tool. It'll help them to do things better.
Correct.
And I think it'll evolve. And there are small things which we can add value. I think we don't have to do groundbreaking innovations every time.
Yeah.
We also see, and this is the learning which we have got, like product innovations are a little larger. But then when we are going in for implementation, in order for the implementation to be successful, we'll have to actually make small innovations.
Correct.
Because without that, actually you're not reaching the last mile.
Right.
So I think that also, if you miss out, it doesn't create the full impact what you really wanted it to be.
Yeah, no, absolutely. I think technology is supposed to solve the problem which is real and not create fancy technology.
I know.
So, so after this, what is next for Forus Health? How do you see the future?
I think couple of things. So we started with a mission of eradicating avoidable blindness. We continue the same journey.
Yeah.
And in this process, we have learned a few things. We started, we were nobody. So today we are looking at how can I imagine vision care
Okay.
as a next step. So we have come up with I'm really proud of that innovation, what our team has done. And I think it's a little bit of a groundbreaking. I don't know whether you wear spectacles, but if you wear one, so you go to an optical store, they test your eye power
Yes.
using a machine. That machine gives you a number, and then you're made to look at a chart.
Yeah.
And a qualified optometrist will put those lenses, and whatever lens is the most comfortable one for you is your final prescription.
Yeah.
Now, the problem both in Western and in developing different problems is the lack of optometrists. So even in India, I think there are only 35,000-40,000 optometrists.
Okay.
US also same level. So getting a qualified prescription
Yeah.
and thereby wearing a spectacle which will suit you is very critical. And an optometrist is not going to be there in remote villages because there is no ROI for him.
Right.
So we have come up with this innovation where you wear a wearable, and then that is connected to a phone. And instead of these physical lenses, there are only two lenses, and I can change your entire power using the phone, which is connected over Bluetooth.
Wow.
And we have already now made it remote. So the optometrist need not be next to you. The optometrist can sit in Delhi and do this to you.
Yeah.
So you respond the way that as if he's next to you, but actually he's remote.
Okay.
So we are combining that with, so anywhere in the world, if this hardware is available and you train an ASHA worker equivalent,
Yeah.
they can just deploy it on you. Their job is to just put it on your head
Correct.
and make you look at the chart, and then the remote optometrist takes it over. So no other device like this exists. So we got a couple of patents awarded on this. So this we think will transform. And then we are adding things like, okay, the moment your power is fixed, then I use AI to look at your face contours. I measure your interpupillary distance, your nose bridge and all that. And then I showcase few frames for you.
Yeah.
You choose what looks good on you. Your final prescription is ready. You swipe your card and order from whichever manufacturer you want, and it get delivered to you in 3 to 5 days, depending on where you are.
Yeah.
So that way, we are ensuring that the biggest problem, refractive errors, will get sorted out.
Yeah.
And then taking that, we want to do the next step of chronic patients. We want to ensure their disease management, because retinopathy and glaucoma and macular degeneration are chronic diseases. They are not like cataract where you do a one-time intervention.
Correct.
So we need to contest. So if you are 40 and you're diagnosed with diabetes and you live till 80, the next 40 years is potential chance for you to lose your vision on retinopathy. So you have to be checked twice a year so that you don't get into retinopathy. So that is also something where we wanted to play a role in technology, where we consistently ensure that a qualified patient doesn't go into vision threatening. One is looking at the billion people and identifying who this 100 million are.
Yeah.
And then this 100 million, we'll have to ensure that they don't go blind.
Yeah.
By ensuring that they are continuously screened and connected to the hospital they are connected.
Correct.
So that the doctor intervenes as and when there is a vision threatening problem. So that's where we think we want to go.
Wow, I think this sounds very exciting, and we'll look forward to when this gets launched and you start implementing it. And I'm sure.
No, the wearable one is already launched in the US. So this is the first product which all the products till now we have made in India and launched in India first before taking it internationally.
Yeah.
This product we have made in India, but actually launched in the US. We got the FDA, we launched in the US.
Okay.
We will launch it in India only next year, because I want to build some economies of scale where before I launch in India.
No, makes sense. Makes sense. Thanks a lot, Chandrasekhar, for spending your Saturday evening with us today. Any last words for our audience before we wrap up?
I think it's been a very satisfying journey, even though it's not a very glamorous business, right? It's hard work. It's all done because of the team.
Yeah.
I think, having a vision or a dream is very easy. Actually implementing it is very tough. Right. And the implementation happens because the team, especially my management, have been so good. Our management team have been staying with us for the last 10, 12 years.
Wow.
The second is even our next generation people. They're all with us for like 8, 9, 10 years. So they've actually dedicated to the cause, and they have kind of built these products which are world class and selling. So I think this all happened because of them, and we're so happy that we have been able to make a small impact in this preventable blindness space. I think one small thing which a lot of people ask, what is what you want to tell to some entrepreneurs? I'm not so big to say, but only thing from our experience, what we have learned is understanding of the problem very deep actually helps you to create solutions. I think that 4 or 5 years of understanding, we never had any idea. We didn't know what to do, right?
Correct.
But it was only understanding the problem without the solution. We never even know. The solution came out of understanding the problem.
Yeah.
So the problem understanding itself, we spent 4 years just to keep thinking, both behaviorally, because I think understanding it behaviorally is also very important.
Absolutely.
It's not just technology. It's about, even if you make something, will people use it? Right? So is it behaviorally connected? So I think that, I would say, if we can do that, I think India is, and Bangalore is extremely good to kind of create solutions for any problems in the world.
Correct, correct. No, I 100% agree with you on that. And on that note, thanks everyone for tuning in today. We'll catch you in the next episode.